morning, afternoon, and evening. Welcome to the Asia Pacific Action Alliance on Human Resources for Health's plenary session on addressing healthcare workers' challenges in response to COVID-19, sharing experiences, and drawing on country's lessons. My name is Marilyn Crane, and I'm pleased to serve as the moderator of today's session. The COVID-19 pandemic has disrupted all aspects of normal living across the globe, including education. Due to safety concerns for students and teachers, classes and school activities were suddenly suspended, and educators had to turn to non-traditional modes of teaching, such as online courses, in lieu of traditional face-to-face instruction. Health professional education also was significantly impacted, including the suspension of practicum in hospitals, health facilities, and communities. This session built on the third theme of the webinar series, Health Professional Training and Education in the Context of COVID-19 Pandemic. And it follows from an October 9th session on this theme. The objectives of this session are twofold. One, to synthesize national and global experiences in health professional training and education in the context of COVID-19 pandemic. And two, to identify policy recommendations on health professional training and education during and after COVID-19 pandemic, as well as preparedness for other public health emergencies in the future. We are pleased to start today's session with a presentation by Dr. Peter Cowley. He's the director of the Health Systems Division of WHO's Western Pacific Regional Office. Dr. Cowley will present a summary of findings of the webinar series Objective 3 on health professional training and education in the context of COVID-19. The first and only episode for this theme took place on October 9th. Dr. Cowley, I welcome you to begin your presentation. You have 10 minutes.
Firstly, I'd like to thank you very much. I'd like to thank everyone for attending. I know it's a bit of a strange hour for some, and I'd also like to thank the conference organizers for being such a diligent and efficient host, and it's always a pleasure to work with them, and we look forward to doing so into the future. On October 9th, the Asia Pacific Action Alliance on Human Resources for Health, in cooperation with the World Health Organization and the various regional offices, Southeast Asia, and Western Pacific Regional Office, as well as the Eastern Mediterranean, along with our good friends at the Asian Development Bank, JICA, United States Agency for International Development, and PMAC, as well as our very good friends at International Health Policy Program Thailand, held the last webinar in its 2020 series, Addressing Healthcare Worker Challenges and Responses to COVID-19. The theme was around health professional training and education in the context of COVID-19. We had some very interesting speakers from UAE, United Arab Emirates, Sri Lanka, and Malaysia. All of them highlighting the interesting challenges and innovations that healthcare professions are faced with in the light of COVID-19. If I could turn to the next slide, please. Next slide. The impact of COVID-19. We know that there's a huge financial impact in terms of reduction in business activity and government revenue. We also know that this has affected the access of essential health services, but with reference to today, we know that it has had a huge impact upon the human resources for health. We know that every country in the world has been affected by COVID-19, some more than others. We also know that health professions and the provision of health needs to move on. So it is one of the early adapters in terms of change that needed to happen, because healthcare doesn't change day by day. You need it every day, as opposed to going to a movie where it's optional. Healthcare is not optional. So some of these changes had to happen rather rapidly. And congratulations to many countries and in doing such. Health profession education was particularly impacted in the early stage of the pandemics. Schools, universities closed, redeployment of teaching staff into clinical roles, and early clinical deployment of students and trainees. Some of them quite heroic. Some of them have actually lost their lives in the provision of COVID-19 care. And a salute to all of those that do every day go on the front line. After the initial wave of infection has passed, attention turned to restarting the health professions education. However, what has been simple tasks have become complex as educators and institutions grappled with ongoing restrictions and face-to-face instruction. Travel, movement, social distancing, and all under the demands of you're still needing to provide clinical care. It doesn't stop, like I said. Day in, day out, every day, every hour, clinical care still needs to be provided. However, some of the associated institutions which provided this pre-service and inter-service training were closed. So it is, again, noteworthy some of the changes that have happened in order to meet these challenges. It's absolutely vital that ongoing training and production of healthcare workers continue. It's, if anything, the demand's going to grow. We know that there's a lot of pent-up demand associated with delayed or foregone care, as people are afraid to go to the clinics for fear of catching COVID-19. So, and there's also the associated need with deploying the COVID-19 vaccination when it starts to roll out. So there's some tall orders that need to be considered. So it's not only in meeting the challenges of COVID-19 in terms of providing safe and effective care, but also trying to meet the challenges of COVID-19 vaccination as well as therapeutics. We heard from views from UAE, Sri Lanka, and Malaysia, as well as commentary from the UK, which was particularly noteworthy. If I could move to the next slide, please. For challenges for students and educators. The immediate response to school closure and distancing requirements was to move to online teaching and learning. This was adapted by all three of the countries that were just mentioned who participated in the webinar. It should be noted that in areas of high internet penetration and connectivity, such as UAE and Malaysia, there's still issues around ensuring universal connectivity. I think most everyone on this webinar has experienced disruptions in internet connectivity and the frustrations thereof. You can imagine for a student who doesn't have doesn't have the financial resources to access broadband and how difficult that must be. The new methods of learning employed both synchronous and asynchronous methods, including online lectures and discussions, more innovative ways to delivering content and testing knowledge. UAE presented as virtual problem-based learning and simulation, and Professor Reed reflected on the potential that and virtual reality. Could I ask you to turn your microphone off if you're not on? Thank you. And on augmented and virtual reality. This move to virtual learning poses some specific challenges for health professionals. How do you teach physical skills? I'm a physician, and I couldn't imagine how I would have learned to examine a patient without actually being next to the patient. How do you auscultate? How do you listen to lungs? How do you get better at it? How do you become competent? These are indeed unique challenges. These subjects form an intrinsic part of many health curriculum and necessity have been balanced alongside the theoretical parts of the curriculum. Final year students and teachers have also struggled with delivering the challenge of finding suitably robust mechanisms for assessing them and making certain that they meet minimum criteria to practice their health profession. It's a tall order indeed. Next slide, please. Evolving clinical education. It had already been evolving prior to COVID-19. And one only has to look for those of us that trained, some may say decades ago, and to look and see how students had been trained immediately prior to COVID-19. Already the internet and computers and algorithms had replaced what in my day was lecturers giving physical lectures in a cramped classroom. So what does this mean for the future? health profession education will inevitably revisit the intended learning outcomes of the curricula to outline the delivery modality. What needs to be taught online, in a lab, in a ward? It has taught us to completely evaluate what is the necessity of the physical presence. Is it just around examining the patient? Is there a necessity for having 500 students crammed into an auditorium, even during times after COVID-19? Many of the tools and policies to enable this innovation existed, like I had said, way before COVID-19. But the pandemic has a bit of a silver lining. That silver lining is it's accelerated change. It's accelerated change in terms of service delivery changes, telemedicine. It's also accelerated change in terms of learning, and in particular, learning around health. Running effective classes by webinar, it was unthinkable 15 years ago, and now it's the norm. It will continue to be the norm. What the key is identifying what are good practices that will enable progress towards UHC. Some of these practices in this space, as well as in other spaces, have been allowed on a temporary basis. They've been allowed on an exemption basis. Some of these practices need to continue on in the post-COVID space because they're good practices. They're efficient, they're effective, and they increase access. So what the key is, what is good and how do you determine whether it's good? And how do you convince policymakers, parliamentarians, budget officials that you should continue on with that practice, which had been prior given on solely a exemption or temporary basis? This and the point was well made by the presenters over the last few days in the conference. In order to manage these new systems well, there has to be a high level of support from students and teachers. We need to find innovative ways of managing these changes, of funding these changes, of delivering these changes in a cost-efficient and cost-effective way. We've all evolved. We evolved from reading tablets. We evolved from writing on walls. We evolved from writing on paper. In my lifetime, I still remember seeing the first fax and being absolutely amazed at such. And to think from the time of seeing the first curled page of a fax to internet-based learning for students, it's been a very rapid change, and it's become even more rapid in the last 8 months. We must be able to identify and analyze these changes and to make recommendations and to work towards implementing them and having them part of a government program into the future. Next slide, please. Future healthcare workers. They should have a greater knowledge of population health. I think that most every country would realize that there has been a need for population health, in particular services around identifying and assisting those in the population who have been never identified. These are the people that have never seen a birth registration, they've never seen a birth certificate. They're in the cloud somewhere. And these people are the ones that need to be identified in order to provide care. It's part of the responsibility of society, and it's also part of something that we need to do. And this has been highlighted by the impact of COVID-19. When society has a hole or multiple holes, it only gets worse during times of COVID-19. We need everyone to be identified and everyone to be assisted and everyone to join in combating this pandemic. Public health. Again, when I went to medical school, I was the only public health graduate out of 165 people. That's changing. We need to continue that change. We should not be around those specialties or subspecialties which make the most money. It should be around those specialties which provide advancing towards universal health coverage and advancing society in general. Teamwork always remains something that we need to improve upon. Understanding about health systems, understanding that it's not just the provision of clinical or treatment services, it's about where that person lives. It's about, is that person's grandmother or grandfather having trouble getting outside of the house? Is it about a young nephew on drugs and stealing money from his grandmother's purse that was supposed to be used for diabetes medicine. It's more than just the provision of care, especially treatment. We need to understand more. We need to understand more about the people that we serve. We also need leadership. It is shown that the countries that have had strong leadership, especially in terms of combating the COVID-19 epidemic, have also proven to be strong leaders in terms of advancing their countries socioeconomically. These are the kind of leaders and leadership, not just at the top, but through all cadres of government, the private sector, as well as non-governmental organizations.
Dr. Cowley, we are going over time, so if you could start wrapping up so we can move on.
And the best part is it's one more dot point. The engagement with the population we serve. It's very difficult for us to help those that we are supposed to be helping if we have no idea who they are or the challenges that they face. Next slide. And that's it. That's me. Thank you very much.
Thank you so much, Dr. Cowley, for presenting the summary findings from the third webinar series in such a cohesive and understandable way. I think you made a lot of very important points, particularly about how COVID it has the potential to revolutionize health and medical education training, but also the need to take advantage of the situation to reach out to those who aren't being served by health systems at the moment. Right now, we'll be turning over to the panel portion of the plenary, where today's speakers will have an opportunity to provide their reflections and insights on the summary findings that Dr. Cowley presented. Due to the high volume of participants, microphones have been turned off for audience members. However, we'd like to promote as much as possible audience participation. So you do have the option to write any questions that you have for Dr. Cowley or any of the panelists in the chat box. And not in the chat box, but the Q&A chat box, please. And then we will use them as part of our Q&A, which will come after the panelists have spoken. So now I would like to turn it over to Professor Wanmecha Chunkung-Kao. She's an ophthalmologist and serves as an audit committee chair under the Thai Medical Council to oversee academic institutions in Thailand. And she serves as a secretary on the National Commission for Strategic Movement on the Development of Workforce Education in the 21st Century and the Health Professional Education Reform Foundation of Thailand. Dr. Wanmecha, would you kindly begin your reflections? And you have 10 minutes. Thank you.
Good morning, good afternoon, and good evening to colleagues. Thanks to Marilyn for your excellent introduction, and thanks to TPRH team who organized this virtual meeting perfectly. Today, I'm going to bring to you health professional education and training in the context of COVID-19 pandemic, from challenge to change. I will be focusing on medical education in Thailand. Three issues that I would like to cover today. The first one is COVID-19 pandemic in Thailand, and the second one is health professional education and training during COVID-19 transition, and the third one is challenge and change for sustainability. I would like to briefly touch a bit on health profile of Thailand. Our current population is 60 million, slightly more than today COVID cases, which are 57 million cases. The doctor to population ratio is 1 per 1,400. And there are 23 universities in Thailand, produce approximately 3,000 doctors per year. During COVID transition, everything changed tremendously to virtual learning, virtual music, virtual meeting, though I am not a virtual speaker. In Southeast Asian countries, Thailand is the first country that reported a case of COVID-19 outside China. The first confirmed case was announced on January 17. World Health Organization declared COVID-19 pandemic on 11th of March. Thai government announced a nationwide curfew on April 3rd in order to reduce the COVID surge. After the curfew has been placed, new COVID-19 cases was continued to fall, though our academic year normally starts in early July. The situation of COVID-19 caused changes in planning and implementation of our educational programs. In March, university was given autonomy by the government to design and adjust an academic calendar and flexibility on assessment to prioritize the safety of staff and students. In order to stop and slow up the spread, the undergrad students were sent back to their hometown and allowed to return to campus in August after the curfew lifted. All classes were canceled. Two groups of teachers and postgraduate students were allowed to work separately and took turns on their working days, switching every 2 weeks to contain the spread of COVID-19 if exposed. In July, prior to the announcement by the government for gradually lifting the lockdown, classroom teaching was started and substituted by synchronous online teaching, in addition to the existing asynchronous on-demand learning, but critical practices were mostly suspended. The onset of COVID-19 pandemic raised significant concerns on moving pedagogy online. Though digital technology and innovation has recently been set as a key strategy in the 20-year national strategy of Thailand starting from 2018. And also information and communication technology for education has also been implemented by the National Commission on Health Professional Education Reform start from 2014. Planning and preparing school before the opening for the new normal education. Upgrading ICT skill for teachers, training on using PPE for their safety to protect themselves, promoting behavior that reduce virus spread and concern for learners, including insurance application for teachers, learners, and support team. Prepare for the access to necessary technology and train support team as well. However, each health professional councils usually runs national licensing examination around this summer time. Therefore, to control the fluid situation of COVID-19, we developed exceptional arrangement for this time. The Board of Professional Council decided that it would not be possible for students to sit their paper-based examination in the traditional way and shifted to online written examination in response to the crisis. Educational examinations were strictly underway under socially distant conditions between desks at allocating testing sites. Students were asked to arrive early for temperature checks and had to wear a face mask, and then they took tests on the computer or tablet which they had access to. In terms of university entrance exam, though the written exam has been completed, the oral examination for university enrollment was also adapted to the new dates for the examination. Postponed examination by a few weeks was also happening or adopted in different approach. In some universities, the oral exams are planned to go ahead on schedule under socially distant conditions. The spillover of COVID-19 pandemic brought the traditional education to take a backseat, and flexible technologies took the spotlight to achieve an acceptable effectiveness. In Thailand, the Faculty of Medicine of Public Health of Her Royal Highness Princess Julapon College of Medical Science conduct a modified multiple mini-interview for candidate selection by using a virtual interview with structure, standard of operation to assess their characteristics in different domains, such as ethics, morality, communication skill, and critical thinking. And also another example, virtual microscope was a new teaching learning tool to replace the conventional light microscopic in terms of undergraduate teaching in pathology. Next generation assessment is, this is the photo of online listening oral examination site. You can see the partition between the student. And next generation assessment is high stake assessment. The measurement was generally accepted to evaluate for validity, reliability, feasibility, educational impact, acceptability, and also the process was very stressful due to lack of in-person environment during the assessment and unrecordable for evidence of final scoring. This is for fairness. Our team conduct a survey to determine postgraduate students' attitude towards online assessment. 116 ophthalmology postgraduate students were enrolled in to SIS examination, took pre and post-test with 4 questions assessing attitude towards online test with a 5-point Likert scale. Attitude and satisfaction scores were analyzed. 4 questions are: taking online test is respectful for preparation. I understand clear instruction. I like taking online test. I feel confident taking online test. There was a significant difference between learner pre and post-test scores. Student perception of online assessment has a potential role in postgraduate student examination because its feasibility and stressful in a family environment. New education learning from challenge to change. Health professional education must meet contextual health security and health system. Digital transformation and health security, for instance, pandemic, handmade, and national disasters. Despite increasingly digital world, the power of in-person interaction is now more variable than ever. Nurturing the collegial-based relationship will ensure long-term partnership with its technology partners by spending time together. Learn the crisis as an opportunity to use innovation and creativity to recover better, not only recreate and go back to normal, but fulfill the ambition to create more sustainable and connected society that are able to put innovation ideas into the service of their own development. To sustain the change, key players are playing vital role to sustain the change in different settings. The first key player is policymakers at different levels, government, ministry, institution, university, to enlist flexible policies such as autonomy. The university works swiftly and diligently to physically and psychologically support faculty, students, and staffs to ensure continuity in teaching and learning, support resources and platform, not only technology platform, but also sharing platform. The second key player is trainer to develop new set guidelines, instructional material, create student engagement activities, and construct cost-appropriate assessments. Research and development is very crucial. It needs to make more systematical analysis and development with evidence generation to evaluate instruments prior to use in the new learning environment, evaluate the outcome, scale up, and create policy dialogues. The third key player is training. Cognitive skills, for instance, teamwork, leadership, critical thinking, decision-making, and problem-solving are all crucial. Not only competency, but locally relevant to their own community, networking across the globe around lifelong learning. The pace of change in our world is accelerating. The skills need to thrive today and in the future will also evolve. As a result, some of what we learned in the past and what we know today may not be relevant. Human beings are natural learners with a need to constantly develop and improve ourselves. I'm gonna close my talk with what we certainly need. Health professional education system that is globally responsible and locally engaged. We need that. For our platform sharing, we're gonna conduct the first global health professional education conference tentatively in March next year on how education sector respond to VUCA health system. I cordially invite all of you to join us, and you can learn from our website as posted in the slide. Thank you so much.
Thank you so much, Professor Juanita. I think you presented you provided great insight and context in how COVID-19 affected the education system in Thailand, particularly around health professionals. And I think your presentation highlighted the need for a toolkit to address these kinds of this huge disruption, which includes a blend of synchronous and asynchronous training. That there's a need to create this opportunity to use creativity to kind of harness this creativity and to harness this creativity and to serve the overall country needs and kind of bring opportunities out for innovations. You also, towards the end, you cited the need for an enabling policy environment and ensuring that trainers are trained up in this new kind of pedagogical future for health education. And you also touched upon the need for trainees to receive more of kind of the soft skills, but just as very much essential towards creating a functional health workforce, which are skills such as critical thinking, leadership, team building, and decision making, all very important for workforces, as well as building these new these new teaching tools and non-traditional methods into lifelong learning. And I think that the audience will be very interested to participate in the conference that you are planning for this March. So I encourage them to do so. Next, I would like to introduce our next panelist, Dr. Marilyn. She is the current chair of the Commission on Higher Education's Technical Committee on Nursing Education. She's been a member of the Commission for Nursing since the early 2000s, and as part of her role there, she spearheaded the quest to ensure the quality of Philippine nursing education. Dr. Marilyn, would you kindly keep your remarks to 10 minutes? Thank you so much, and please begin.
Good morning, good afternoon, good evening. Thank you very much, Marilyn, for that introduction. And I'm happy and honored to be here to share some reflections on health science education. And I would like to thank the AAAH for giving us, the Philippines, an opportunity to share our thoughts about this. Okay. My reflection outline shows that I will be giving 3 main points only. The COVID-19 implications to health science professions, actually a short commentary on the summary given to us by Dr. Cowley, the need to revisit transformative health education, especially its vision, and the last point is how do we craft resilient but transformative science education. As mentioned in the webinar 3, there were a lot of COVID-19 implications to health professional education. So the pandemic brought urgent and abrupt need for health sciences education, innovations, implementation. Some countries' educational systems, as pointed out, were ready and pre-positioned, while some were not. However, based on webinar 3 counts from Sri Lanka, Malaysia, I forgot the other country, they did come up with inspiring innovations combining both synchronous, asynchronous methods, as well as coming up with other pedagogic methods to strengthen these new methods. However, if we look into the discussions, it also emphasized the need to continue systems changes. The reforms of transformative education that was introduced in 2010 is something that I think we need to really look at. So what is the vision of transformative health professional education, and how is this related to COVID-19 and what we're grappling with in health science professional education? The vision of transformative health professional education specifies that all health professionals in all health countries should be educated to mobilize knowledge and to engage in critical reasoning and ethical conduct so that they are competent to participate in patient and population-centered health systems as members of locally responsive and globally connected teams. This was also mentioned by Dr. Cowley and I think Professor Wichitak just a while ago. The ultimate purpose of the introduction's transformative health professional education is to assure universal coverage of high-quality comprehensive services essential to advance opportunity for health equity within and between countries, which is what we're moving towards in UHC. And more importantly, transformative education in its vision links educational systems to health systems so that we can all together achieve better health outcomes. I'd like us to quickly revisit this vision and also some of the important aspects of what transformative education is trying to do. It was trying to move all of us globally to redesign and innovate professional health education. And this was deemed necessary because there were a lot of opportunities that we had to actually take advantage of. The first one was opportunities for mutual learning and joint solutions offered by global interdependence. In 2010, this was already realized. And so in addition to this, there was also acceleration of flows of knowledge, technologies, and financing across borders, as signified also by migration of both professionals and patients across countries. There were also new health challenges, including new infections, environmental, behavioral risks, rapid demographic and epidemiological transitions that were predicted to threaten health security of us all. So now we are grappling with COVID-19, a pandemic that no one saw coming so quickly. So we need to really develop, as a result of this, resilient health professional education that is pandemic, disaster-proof, and responsive to current and future needs. And what does this mean? It means that our systems must produce graduates that are fit for work and fit for practice professionals on day one. Right now, there is a disconnect between basic in-service education and the work that is needed in the field. But that is something that we have to solve with our resilient educational systems within the aegis of transformative education. Interprofessional education is also necessary so that we can build better teams and use multi-professional approaches to the solution of complex diseases and health problems, especially in public health. Collaborative care is something that we aim for, and we would like to involve the community, people as co-producers and drivers of health needs and demands, both in educational and health systems. Right now, the providers drive the demands and sometimes come up with conjured needs. But it would be great to have families and the communities as co-producers and drivers of our health, professional education and our health system services. Pedagogy should be flexible and accessible, as experienced by many countries. We have to engage in flexible learning options, and these are operated with recognition that health workers need to be lifelong learners. Those of us who teach our students should not aim to teach everything, but we need to teach our students how to learn and point them in the right direction to continuing doing this throughout their careers. Finally, there should be seamless transition from basic pre-service education to in-service training using appropriate and accessible learning management systems. And this is more difficult in developing countries like the Philippines, but this is something that we all have to prepare for, because COVID is going to be with us for a number of years more, and after COVID, who knows, there might be something else that will come that we need to prepare for. So the focus on nursing and midwifery education points certain things. First, there are challenges, special challenges in nursing education. Taking the cue from Dr. Cowley's presentation, the most challenging are physical skills training, clinical practice, change management, and balancing education with COVID-19 response. This is because nursing students have been also requested to offer services while they are in training because of shortages in health human resources during the pandemic. But it is difficult to train clinical skills if we use the new, especially synchronous pedagogy and approaches. Specific to nursing and midwifery, these two are nurturing and high-touch caring professions. So how do you develop empathy, compassion on the one hand, and leadership and managerial skills using flexible learning options? We do have high fidelity simulations, and we have patients that can be used for assessment, but simulation labs, synchronous, asynchronous materials were found to be limited to accomplish all the program outcomes, especially in the soft skills, which is very important for us, for these two professions. There is also this move towards advanced practice nursing. Nurses can assume and should assume more visible roles in infectious disease, NCD care, including mental health at the primary care levels. And this might lead towards independent and collaborative practice. In the Philippines, we had a new UHC law just passed last year, and nurses are now being drafted or prepared to be drafted to man the primary care levels along this line. The midwives are also advancing midwifery education. They now, from a certificate course, they now have a BS program, and they are producing their first few batches. So with this transition, it is difficult to be using asynchronous and synchronous methods right now that are not yet tried and tested.
Dr. Marilyn, I'm just informing you, you've passed the 10-minute mark.
Oh, sorry, the last slide.
Yep.
Okay. So what do we do with this? We'd like to move towards resilient and transformative health workforce education for improved health outcomes. And I propose four aspects to be changed. First is to expand health workforce education and training beyond health professionals. What do we do with community health workers and families who have to be our partners? They too need training to meaningfully participate in UHC provision. We also need to craft global collaborative educational and training policies that will accelerate flows of knowledge, technologies, and financing across borders. We need to increase investments in health workforce education and training across pre-service, in-service to advanced degrees. And this is where we need to emphasize the sharing of educational and training technologies across countries, across the first and the third world. We need to improve the investments because in 2010, this report showed that education and training only had 2% of total health expenditures, and this needs to be increased. And finally, we need to advance interprofessional care through interprofessional education so that we can create better health teams capable of collaborative care. If we're able to do all of that, then we have a fighting chance to deal with pandemics like COVID and other health problems, and also that will also protect us from future disease problems as well as disasters. Thank you very much for your attention. Mabuhay.
Thank you, Dr. Marilyn, for your insights into the impact of COVID-19 in the Philippines and health education there. You emphasized the need to continue to pursue transformative education policy and linking the educational system to health systems for better health outcomes. And you also talked about the need to develop resilient health professional education programs that are pandemic, disaster-proof, and responsive, which I think is very timely right now and an important thought. You had an emphasis as well on lifeline learning and expanding the health workforce and education and training to reach beyond traditional health workers to community health workers and their families, and kind of establishing a global policy and framework for training that would also help promote increased investments in the healthcare policies. So I think there was a lot of really insightful information that was included in your reflection. So thank you for your time. Next, I'd like to invite Dr. Mohanad. He is the Executive Director of the Eastern Mediterranean Public Health Network. He has led MPNet since 2009. He also has served on several regional and global initiatives, including the Steering Committee for the Global Outbreak Alert and Response Network, or GORN, as well as TechieNet. Dr. Mohanad, would you kindly begin your remarks? And we ask that you maintain them to the 10-minute time limit. Thank you so much.
Thank you. Thank you. Good evening, good afternoon, good morning, everyone. Thank you very much for facilitating the session, and thank you for our colleagues and attendees for this session. I am going to present, some sort of exchange knowledge and information among different regions. So I am coming from Eastern Mediterranean region, and I am aiming, to share a little bit about our experience and drawing, the regional experience and lessons learned from what we are facing now. So as you know, COVID-19 has affected almost every country. COVID-19 has overburdened the health system and exhausted its resources, including the human resources. Overall, health system in Eastern Mediterranean region has improved, increase in life expectancy and halving infant mortality rate between 1980 and 2003. The network of health services has expanded and major health gains in terms of processes and outcome. However, even before COVID-19 pandemic, the health system suffered major challenges. So, mainly in my presentation, I will be focusing on public health workforce. So what we mean by public health workforce is public health workforce could involve leaders and managers of health systems, in addition to providers of population healthcare. The main enabling requirement to perform the essential public health functions, according to the WHO framework, is sufficient and competent health workforce. Health workforce has become a major concern, and the health policy issue around the world was the focus of the World Health Report in 2006. Improving health services coverage and equality depends on availability, accessibility, and acceptability, and the quality of health workforce. There is a positive correlation between the density of the health workforce and population health outcomes, according to that report. Investment in health workforce through scaling up health employment will lead to inclusive economic growth. So what about the health workforce facts in IMRO region or in Eastern Mediterranean region? The region suffers an overall shortage of qualified health workers with suboptimal and imbalanced production and availability. The need was estimated to overall 4 million in 2013 and projected almost 6 million in 2030. Among others, this gap is a result of brain drain of the qualified health workforce out of the region. 7 of the East Mediterranean member states are in the health workers crisis with densities of health workers below the threshold of 23 health workers per 10,000 population. So more challenges, policy development, long-term vision and planning, capacity of the health workforce development is inadequate in Eastern Mediterranean region. Data about the public health workforce are limited and information are scarce and sometimes it's lacked. Ambiguity in terminology as a classification of health workers vary across countries, and we do not have something unified to follow up. The dissemination number of workers because of retiring and immigration of public health workers. And as I said, we are facing a huge brain draining from our countries. Job losses associated with budget cuts. So more, difficulty recruiting new workers because of non-competitive salaries. Nowadays, our MOH in the region and other, health sectors are facing a huge challenge in offering non-competitive salaries and benefits. The gap between workforce skills and capacity caused by changes to public health practice, lack of formal training in public health for the majority of public health workers, and finally, limited training opportunities for current workers. So the health workforce production in the region is imbalanced and inadequate to bridge the gap in health workforce availability or the raising public health demands. During the past 60 years, there has been an increase in the number of medical schools in Eastern Mediterranean region from 18 in 1950 to over 300 in 2010, with very few schools of public health. Only few countries in the region poses schools for basic and undergraduates and graduates, public health degrees. Moreover, there are fewer than 10 independent standalone graduate schools of public health, only one of which in entire the region offers a doctoral degree program. The graduates of community medicine program represented only 3% of the total mass of graduates over the last 30 years. Besides public health education inside the region, some countries operate a scholarship programs sending candidates to universities in the West and US or elsewhere to obtain qualification in public health. The contribution of private sector to health workforce development, health force production is focusing mainly on medicine and curative science rather than public health. As I said, the main challenges are related to quantity, quality, and relevance. Most of the education programs offer long-term certificate programs. They do not suit the employers as they add to the gap because of the absence of and full-time study. Others are not based on the training, need assessments that reflect the actual needs and competencies and the skill to deal with existing challenges for health system. Many excellent training programs are provided outside the region, which makes them inaccessible, unfortunately. So this is, countries in the region can be categorized into three broad groups based on population, health outcomes, health system performance, and level of health expenditure. As you see, we have three zones or three groups, and they are mainly classified in this situation. So already we know the health workforce challenges that we are facing in the region. This is to provide us with the background information that we need to improve our public health system. So during COVID-19, health workers play a crucial role in managing the pandemic. In many countries in my region, public health was not fully recognized in many countries and by the authorities. Nowadays, many countries realize the importance of public health in this regard. Hospital was overwhelmed and could not cope with the pandemic in the most of the countries, including Western countries. Rethinking the role of hospitals and the other institutions as hub of care where people should go first. Designate and prepare hospital to mobilize surge acute of ICU capacity and approximate mix of good quality hospital primary health care. As our colleague said, about the universal health coverage, primary health care role, services near people home are so important, can be life-saving. More investment on primary health care and non-measures to prevent the spread of infection. One of the major initiatives in the region was related to rapid response teams. Rapid response teams have effectively contributed to the detection and management of COVID-19. Many countries require large number of trained medical staff. If we take USA as example, US requires 100,000 workers and almost $4 billion in US if we need to conduct manual contact tracing. Community-based organization could have contributed more in fighting COVID-19. This is one of our limitations in the region. But moreover, community health workers can play a role in community-based COVID-19 emergency response team. So
Dr. Mohammed,
yes,
you're
yes.
approaching 10 minutes. Thank you.
Okay, thank you. So most of public health programs in East Mediterranean program is delivered on campuses, face-to-face training, teaching together with the practice-based portion to varying degree. Distance learning and blended education approach are not common in the public health education in our region. So just to save the time, I am sure in your region, to best of my knowledge, also you have field epidemiology program, training programs. These programs, were able to contribute in responding to COVID-19 in certain areas like rapid response, samples correction, surveillance, data collection, contact tracing, infection control, and many other things. So final slide, the recommendation. First, we investing in health workforce development is a key factor in strengthening health system and supporting progress toward universal health coverage and reaching sustainable development goal targets. The synergy between public health schools and health services is crucial for achieving the desired outcomes in terms of competent health workforce. Online training became a fact and learning. Teaching public health should be linked to applied research with the research finding, guide, training, and education. Policies are needed to ensure the health workforce retention and safety, and finally, recognition of health workforce is crucial. Thank you very much. Thank you.
Thank you, Dr. Mohammed.
Thank you.
You presented a lot of very interesting information about health professional education in the Eastern Mediterranean region, and I think advocated quite strongly for the need to enhance in-service training and bringing in more of a blended learning towards it. And like Dr. Marilyn, you also emphasized the synergy between public health schools and the health services and how important that those links are towards achieving competent health workforces. You also, I believe, mentioned teaching public health should be linked to applied research, which I think is really important, and that, as always, policy is needed in order to ensure not only a functional workforce, but that the functional workforce retains workers. So thank you so much for that. We're going to move forward into our Q&A portion of today's panel. And so we'll have all of the speakers that we had earlier, from Dr. Cowley to Dr. Marilyn to Professor Wanichi to Dr. Mohammed. They are available to answer your questions. So I noticed we have several questions already in the chat box. The first question from Kate Tulenko: what are your institutions or governments doing to address the connectivity issue? I see that Dr. Cowley has offered to answer this question live. So Dr. Cowley, would you kindly respond to Kate Tulenko's question?
Thank you very much. Internet, and I'd kind of answered in the second one. Internet connectivity, like mobile phone connectivity, is a private sector activity usually. Vast majority of mobile phone and internet providers are in the private sector. And part of the reason for this is because it's very capital intensive. You had to put up all those towers, you had to put the fiber underneath the ground, and it's very maintenance intensive. And these are not areas in which government usually has a comparative advantage. So usually what a government does is that it will have a licensure. It says you are allowed to be an internet or a mobile phone provider. You have this particular specifications, and for this long, for 3, 5, 10 years. And part of what the government does is it says, but there's some provisions in the contract. And the contract is, in this geographical area, you must provide internet services. For instance, if it's a geographical area that does not have internet services or doesn't have mobile phone, and the company sees, you know, I wouldn't make that much money because there's very few people using it. The government steps in and says, well, you, in order to get the license to operate, you have to have some social benefits to some of your internet or mobile phone activity. And these negotiations, you know, are quite varied, but they're a potential source in which countries, especially governments, and if the government does not own the internet providers, doesn't offer an alternative, or is not a mobile phone provider in itself, it's an avenue for mandating certain things that the internet provider has to do in order to establish the license. And this can range from provision of services in geographical areas where there aren't any, certain tariffs, and certain plans. They can even say that they have to have certain plans active for certain individuals, students, elderly, whoever that may be. We are not actively involved in that in WHO, but I just wanted to give you some background as to why it is that often internet connectivity lags behind. And part of it is because it's in the private sector. And the reasoning for that is because it's so capital intensive and it's so maintenance intensive that oftentimes the government says, well, we're going to go to bid for licensure. Over.
Thank you so much. That was, I think, a very helpful response. We have a second question from Maison Calendang. Besides the virtual learning, how do you cope with hands-on learning, which will give you, you know, real life acquisition of skills and competencies needed in the workplace? Anybody, any takers for that? If you want to raise your hand. Okay, Dr. Mohanad, you want to answer that? Great.
Yeah, thank you. Thank you very much. During my presentation, I talked about field epidemiology training program, which is, you know, hands-on, which is in job training classes, and job training, you know, exercises. It's a 2-year, 1 year, or 3 months program where we encourage, you know, and we establish, you know, the training to be in job training. And I think this modality was derived from CDC Atlanta, you know, 100 years ago, and still, you know, prove itself that this is, you know, this type of the programs where we can encourage hands-on training and on-job training to be more efficient during emergency and during, you know, any public health challenges in the region. Thank you.
Thank you. And I wonder if any of the panelists have any experience with some activities, like maybe there's like virtual simulations or something like that, where something, I think, you know, was it Dr. Cal who was talking about, you know, the physicality needed, you know, with some of the medical training, and if there are some virtual methods in your toolkit for addressing that. Yes, Dr. Marilyn, thank you.
Yes, that is a big problem with the nursing education here in the Philippines. So what we did was we combined a lot of resources and methods. For the beginning skills that can be lab-based, we used high and low fidelity simulators to teach nursing students the beginning skills like injections, assessments, and all that. But we have scheduled patient or we have designed patient interaction. So they're given asynchronous activities like in your family, if you have an old person, do an assessment and identify problems of your patient, quote unquote, and report on it and say what your plan of care will be. So something like that. So you start with your families. The plan is that we were hoping that by early next year, by January, we could start fielding students at least in outpatient clinics where they will begin, where they can have real one-to-one patient exposure again, or have hospitals that do not admit COVID cases, because here in the Philippines they started to do that so that health sciences education can begin again. We are looking at fielding students in doing that. Then there is also this move to train patients to simulate certain diseases. Like there would be a diabetic patient who's been chronically diabetic and would open up, he or she might go to the university and be willing for a fee to talk to students who will then question them or quiz them on what care they have gotten, and so continue the plan of care or whatever. So it's a combination, but it's difficult because COVID-19 is limiting access, and the faster that we are able to control the transmission here in the Philippines, the earlier we will be able to do that.
Okay, well, we have a whole lot more questions, but only, maybe three or 4 minutes. So let's try to see. I think there was a question about non-competitive salaries and MRO. Okay, I'm not sure. Let's maybe that. So who would that? I guess that would be directed to you, Dr. Mohanad. And there's another question about what techniques can be adopted to take up public health as a specialty. What concrete incentives can be taken aside from appealing to the nature of people to serve for a greater good? And the third question, Dr. Mohanad, I hope you have the Q&As open about training new nursing graduates for a short time. Would it be sufficient to get involved in caring for COVID-19 patients?
So thank you. Would you like me to take these questions? Yeah.
Yes, but I would like for you to take it in like 2 minutes or something like that.
Okay, I will be sure. So regarding to the non-competitive salaries, in the region in general, we are facing a problem that the primary healthcare triangle is upside down. We mainly focus on curative medicine rather than public health. So I think we need to consider, to encourage, our public health, or to encourage our teams, public health professionals to be public health officers, to encourage, to create them the opportunity to be there, and to try to create some sort of balance and fairness between different specialty in health science. Public health to be equal to the curative health. This is one of the approaches. Of course, incentives there, different modalities. But again, in terms of the question regarding to the nurses, etc., I think yes, we need to make sure two things. First of all, in the past 20 years or 2 decades, the focus was mainly focusing on medical MD doctors. Nowadays, this equation does not work for us in the region, and I think the globe. We need to engage, nurses. We need to engage public health officers. We need to engage lab. We need for all. So we need to adapt our programs, to cope and to fit with these changes. And of course, now with the current COVID-19 situation, we could, and many agencies develop different, crash courses that we can train, for 1 week, 3 days. Sometimes even WHO has 2 hours trainings. One of the examples to see that it was related to the infection control in the hospital. So we need to make sure that we are protecting our colleagues in the hospitals. So any type of training, crash courses, 3 days, 2 hours, we need always, to focus on such on job training, to make sure that we are protecting our, colleagues in their responding to COVID-19. Thank you very much.
Thank you so much. And we've run out of time for the Q&A, but we do have a number of questions remaining. I see one for you, Dr. Juanita, about adapting about medical students, and there's several other, I think, really important questions. We've run out of time for this session, but for the panelists and Dr. Cowley, if you could take some time, go through the chat box while we're wrapping up the session and respond directly to any of the questions that you feel like you would have some contribution to, that would be appreciated. And hopefully we can get their answers responded to prior to the end of the session. So thank you so much. And now it's time to turn over to our next part of this. Before I turn it over, I would like to thank Dr. Cowley, Professor Juanita, Dr. Marilyn, and Dr. Mohammed for your insightful and really critical observations about health workforce needs in these different countries, specifically in the Philippines and in Thailand and in the Eastern Mediterranean, but also more globally, and kind of outlining some important policy recommendations that can be made. My understanding is that the organizers of this event are thinking of having a white paper, and so I think the contributions and even the inputs from the audience members with their questions will feed into that very nicely. So, having said that, I'd like to thank the organizers for inviting me to serve as a moderator. And now I'm going to turn the session over to Dr. Panarat Wisawatapanimit. I'm sorry if I butchered that. She is the Deputy Director of Research at Boromo Rajonai College of Nursing, Bangkok Faculty of Nursing at the Prabowo Chanak Institute. I'm so sorry, I should have practiced a little more. A Ministry of Health, Thailand. She's also a member of the Secretariat for the Asia Pacific Action Alliance on Human Resources. Dr. Panarat.
Well, thank you very much for Ms. Kent and our panelists. So I'm very honored to be on behalf of the Tibet Secretarians to show the result. Okay, so we would like to talk about the plan for next Tibet activities. So the main topic that we would like to present is we would like to summarize our webinar series and plan for next Tibet activities. So today we learned the last sections of the Tibet conference that focus on addressing healthcare worker challenges in response to COVID-19. And we changed from the face-to-face conference that we ever done to be the webinar series. So the main objectives is we talked about challenging experience, about mobilizing such capacity, occupational risk protection, and health professional training and education. So we learned the webinar 3 themes, and we start in August for the first episode. And this is all to be input for the Tibet plenary section, and would like to summarize our result. So we have the to recognize the International Years of the Nurses and Midwives, and we recognize the MDs that we provide award and recognition for the MD nurses and midwives. We congratulated for all of them. And for key messages, I will not talk about that much. We're gonna put on the report, and you can look at on the website. But important points is like health workers are the backbones of the health system, and we have to their priorities for saving lives of people. So we have to save life of them. So their physical and mental health as well as social health workers so are important. So we need to provide occupational health risk protection and infection prevention control principles for all the health setting, and health educational and trainings are disrupted because of the COVID-19 pandemic. So, and we need to continue and to use all the new teaching learning approach that we use, like such as online education, e-learning, or better after COVID-19 as well. But the challenges that we face and we discuss is about faculty and student skill, and about internet connectivities, evaluation methods, quality assurance, and clinical practice. So that is very challenges, especially in some country and in remote and rural areas. So we need strong leaderships of government, multi-sectoral decision making, and collaboration of our health sector and beyond health sector, that we need to respond to COVID-19 timely, efficiently, and effectively. The rapid and correct communication about the COVID-19 for health workers, media, and population are also important. And we need the healthcare worker data. So the policy planning and investment is very important because we need to strengthen HIS capacity, retention, and safety, as well as the health system. And of course, the primary healthcare are very important to build resilient health system for achieving SDG and future public health agenda. And because of COVID pandemic, we may not be able to back to the way we were, but we need to use this important lesson learned for strengthen HIS assistance and future public health emergencies. So for the plan for activity, we still focus on TPH aims to address the global human resource for health, and we want to extend the TPH network and members to EMLO for the next years, and we are going to public the result and policy recommendation of our webinar series. And of course, we will continue to organize the 12th TPH conference in Global HIS Agenda in next 2 years. And we would like to thank our contributor and supporter from our webinar series. We have 9 moderators, 3 keynote speakers, 31 speakers, and we would like to thank the chair and steering committee and all participants. From the webinar 1 until now, we have more than 1,000 participants from 62 countries that participate in our webinar series. And this is we separate from each region, and you see that we have all of the peoples of the regions that attend our webinar series. And we would like to thank our speakers, moderators, and that you contributed for this webinar series. And of course, we would like to big thanks to our TPH secretariat team and rapporteur teams, and who the one that write synthesis report and policy brief recommendation. And of course, this is the pictures of our technical team, the supporting team that we work here, including today, that for run the webinar. And of course, we would like to honor and recognize our health workers who lost their life because of COVID-19. So this is the things that are summarized, and I will be report in the website, and we have the publication. And of course, because of COVID-19, we will not stop here, just only the webinar series. It have a lot of important information, and I think that we would like to announce and invite Dr. Besons to talk about the collaboration between the Asian Development Bank and BMJ. Please, Dr. Besons, you have 3 minutes.
Yeah, thank you, Panarot. I'll try to be as brief as possible. Can we have the slide, please? I'll just be talking. First of all, thank you for AAH, sorry, and for giving us this 3 minutes. Can we have the next slide, please? So the Asian Development Bank has partnered with the British Medical Journal. Can you have the next slide? Sorry. Okay. Okay. In which we have provided what we call an information portal, a training portal. Can we have the next slide? For healthcare workers, in which that will allow them to access BMJ resources on COVID-19. Can you have the next slide? One more, please. Okay, as said, this portal is in English, Russian, and Mandarin. I would have to apologize to some of our friends in EMRO countries, because this will only be provided for free for countries that are members, for healthcare professionals who come from countries who are members of ADB. That would include Pakistan, Afghanistan, and EMRO, but unfortunately, we could not expand it to the rest. Nonetheless, this portal, once you log in, can you have the next slide? So this is how you log in. We're going to share the slide. Next slide, please. It will provide you access to learning materials that has been developed by BMJ, as we said, in Mandarin, English, and Russian. The next slide, which would include learning materials on PPEs, addressing comorbidities, all related to COVID-19. Next slide. We will continue to work with BMJ that more materials will be provided, not just including clinical practice guidelines, best practices, and all that. So we hope that this could be a resource for all of our healthcare workers as we continue to manage and deal with COVID-19. Thanks a lot, Panarut.
Further information from the BMJ, and thank you very much for Dr. Besons to talk about that. Okay, so we are going to, for the closing speech, we have two closing speech. So one is for our TPA chair, and the second one is for our TPA chair elect. So we start with the first one first for our TPA chair. I would like to invite Dr. Thanti Mawang for the closing speech, please.
Thank you very much, Panarut. So, Excellencies, distinguished guests, and ladies and gentlemen, I believe that all of you have enjoyed 3-day plenary sessions, and it is my great pleasure to see that you had fruitful discussions, and I can see the purpose of the seminar has been completely accomplished. I would like to thank all partners, including WHO EMRO, WHO Zero, WHO HUPRO, JICA ADB, USAID PMAC, and last but not least, thank you IHPP's AAAS Secretariat for their continued support in making the series of AAAS webinars and the plenary session a successful one. Our conference has been organized when the COVID-19 pandemic is still going on around the world. So I'm sure that it is a timely contribution by AAAS on health workforce responses to COVID-19, a pandemic in the century. Finally, on behalf of AAAS Steering Committee, I would like to express my appreciations to all the participants for taking time out of their busy duties to attend the plenary sessions. I would like to close my remarks and officially announce the end of the 11 AAAS plenary sessions. Once again, I wish you and your family stay safe and healthy in these challenging times. Now I wish to hand over the chairpersonship to Dr. Tin Tun of the Ministry of Health and Sport, Myanmar. Thank you.
Okay, so next, thank you very much for your leadership, for Dr. Mawang to help with us for 2 years fully for the LAN TPH. So now we would like to the last closing remark is from Dr. Tin Tun. He is from Myanmar and he's a chair-elect of TPH, and he will be chair for the next 2 years. So thank Dr. Tin Tun, please.
Thank you. Good evening, everybody. Chairman of AAA Steering Committee, Excellencies, distinguished delegates, experts from the member countries, our AAA Secretariat, ladies and gentlemen, we have reached the end of the 11th AAA webinar series and plenary sessions today successfully, and I'm indeed honored and delighted to share the closing remarks. As we all know, we initially planned to organize the 11th AAA conference in the theme Accelerate Progress Towards Achievement of 2020 and Actions for 2030 Milestones of Global Strategy on HRH in Myanmar in August 2020. Was looking forward to host this important event in my homeland, take you around famous sites in our nation and meet all of you face to face. However, because of the COVID-19 pandemic globally and its impact on public health, we were not able to do so. In view of healthcare workers who work relentlessly in the front line and taking on high risk to exposure on COVID-19, and the importance of health workforce to be safe as well as rise up to meet the challenges, we, the AAAH, need to address this important global HRH issue in a timely manner. Therefore, our 2020 AAAH conference has been changed into the series of webinars and the theme toward healthcare workers in response to COVID-19 from 17 August to 9 October 2020 with 3 webinars and 6 episodes. There, the main essence and most striking things were further discussed as summary synthesis findings of webinar series as 3-day plenary discussions from 18th to 20th of November. We gathered together virtually via the Zoom and shared the national and global experiences in preparedness and response against COVID-19 pandemic. Distinguished delegates, experts from the member countries, ladies and gentlemen, the first panel of experts addressed in mobilizing the surge capacity of healthcare workers responsible for clinical management and public health actions. We identified challenges and lessons learned, shared successful and good approaches, and recommended effective solutions on the case identification and promote testing and diagnostic, effective contact tracing and quarantine, ensure availability, affordability, acceptability, and quality of treatment and care who became positive COVID-19 and ensure the best clinical outcomes. During plenary 2, synthesis on the summary of webinar series 2, where countries in the Southeast Asia and Western Pacific regions shared experiences on measures in reducing occupational hazards, morbidity and mortality of frontline health workers were addressed. Today, at plenary 3, we are delighted to learn how countries effectively made effort in integrate innovations to ensure continuity of pre-service health professional training in the context of school closures due to COVID-19 pandemic, and healthcare workers in service and graduate training for effective response to public health emergencies. This will not only ensure the quantity of health workers production, but also strengthen healthcare workers' capacity to battle COVID-19 safely and ensure the quality of healthcare providers fighting with this health crisis and global pandemic. Our distinguished delegates, experts from the member countries, ladies and gentlemen, overall, the COVID-19 pandemic has highlighted the need for more resilient public health and emergency response systems, particularly in developing countries like Myanmar and countries in the Asia-Pacific regions. It requires a response that looks not only at the short-term and emergency measures, but also it requires a response that also addresses the deep systemic change and structural policies needed to reach the SDGs and proactive strengthening of the health workforce, both in quantity and quality. Unity is strength and solidarity is the solution. Therefore, I'd like to claim local unity, national unanimity, regional accord, and global solidarity to fight against COVID-19 pandemic and through strengthening our human resources for health, without which all efforts will be in vain. Distinguished delegates, experts from the member countries, ladies and gentlemen, to conclude my closing remarks, I'd like to express my sincere thanks to the AAA Steering Committee and Secretariat and all the stakeholders and experts from 80 member countries and other countries for this excellent partnership in strengthening human resources for health, ensuring sustained commitments addressing HRH needs through research and contribution to strategies and policy development. So I'd like to congratulate Dr. Trendy Mai Ong for her great efforts, commitments, and achievements that she brought to as chair of AAAH during her term despite COVID-19 challenges. It is my great pleasure and privilege to take up responsibility as the chair of the AAAH Steering Committee for the next 2 years and look forward to welcoming you all to Myanmar when we host the 12th AAAH conference in 2022. As we move forward, let us act unitedly within solidarity to protect our health workforce and communities from the danger of COVID-19. Let us implement HI strategic plans, health workforce retention policies and strategies at hard-to-reach and remote areas, and making sure of accessibility, acceptability, affordability, and quality of health services delivered to all population regardless of where they live. Let us think critically and creatively about the actions we can take to bring health safely and make positive changes in the world. Let us ensure that the coming years will be the best case scenario for healthcare workers and everyone. Thank you very much for your kind attention. Thank you.